The small scale where really is more important than I don't know. How do you prognosticate it? The collateral relative was not to one of the event predictors of the material, low CI index, there was higher mix rate. So the iron also has a higher relativity component and offers more protection from steam. So when you use the diagram, the large diagram with more than 2.5 or 2.5, larger derivative of distribution, significant fuel losses, 101, 101, 101, concomitant disease, length of the disease is beyond the oxygen, unfavorable handling, and of course, dissection of compromised flow during provision. So I would like to show two cases. This is a 70% to the complex beyond the large oil index. So the large diagram really decided to open the cycle oxygen with some fluctuations which we documented on lives. And I was showed a very good cycle others this is a dominant circumflex where we extended into the large organ and then we opened the side branch and to the next is the most already done here manual and we in fact we thought we would distort the state and there is some according to the large one and some of the disease we successfully evaluate different extracts and because of the had we could handle this in 30 months so not to do that. This is antibody having a large animal and you see the animal virus snack that will be as a very model how you go to the distance there into the animal. You feed it to oxygen with a evaporate balloon and the iris showed well, this is an animal and it's a good oxygen. This is also specifically in our documentation and we were in mind almost what the traffic patient and we could this is a complex and a young gentleman who was very so we sent it to the complex and started from the start and there was a hematoma at the beyond the oxygen, we could survive it. We had to send this to the large where we use the velocity and had a good result. Thank you.
Thank you.
Just one. Dr. Bhagwat, you have done a good job. Non-left main and left main, you have shown both of them. In how much percentage of cases would you really recommend to use imaging? I mean, in left main, of course, it's almost always should be used. But I was talking to Dr. Fajade yesterday or today morning. He said in France they are not using as such the imaging, not more than 10%. What is your case? You have shown that in non-left main, imaging should not be a major. I mean, it should be used or not should not be used.
So now, I can't tell you what percentage. In India, we need a lot after. Number one insurance, 100% that is number one. In my criteria, either I use maybe for very small lessons, that I think this is much larger. For definitely, there is a large definitely, over afterwards, and small lessons. The rest, in other complex it is not controlled. There is no limit to the idea. You are doing it, and there is no limit. And as Dr. Patel said, other operators in France and Europe, doesn't make it less.
Thank you.
What is the important strategy in long-term bifurcation what strategy to do the key class and mini class of production? Yeah, I would question. I started with DA class, I don't know DA anymore, and I learned the particular. And if I think there are ideas now, I will not technique, what technique, will develop good results. But I am clearly in favor of provisional because the circumstance option is very important. I would rather have a 10-20% residual solution there rather than giving us 10-20% sort of the component long-term problem. So there comes all these topics which can be. So there is a benefit of having this can go on the next conservation. So getting this doing the good job of the process.
Thank you very much. First of all, the contribution beautifully from the University of Bombay, government, and education and support. We are talking about the beautiful scientific sense, and the first point is the understanding modification anatomy both facilitates scientific sense and prevent troubleshooting. It says the document concerning expert consensus of ABC, and you have immediately the conclusion of prevention. And prevention is linked to different risk factors. They can be the unfavorable application angle, the plant, and then you might have troubleshooting. Let's have a look at the essential keys of the anatomy in determining the difficult science. The first one is the plant distribution, then you have the size of the main and resonant assignment, and then you have the modification angle. Here is a typical example of a plant distribution indicated for the patient for the side version. You can see after before and after the landing sent from the distal RCA into the PE branch. Here you have another example of how much if you oversoulding the stents, you might have a different mechanism also when the same time that you don't have a plaque at the origin of this lateral branch, where you have a shifting of the carina that is going to compromise the branch. The angle was totally changed by the standard foundation. The first strong point is what is the best working view to better visualization of the side branch. Here you have an example of what is worse in red and what is good for visualization in green. Of course, the angle is going to make a huge difference. If you have a wide angle, it can be much more difficult for widening the side branch. Less likely is to get a carina shift, and it's easier to get the side branch often covered. Opposite in case of the rubber, where it's easy to widen, but it's much more difficult to cover this costume, and the carina shift is more likely. In this case, we can use a specific technique. When you are in travel, one of the first approaches will be to try to enter the side branch and the rest of the side branch by using a dual lumen catheter. That is a simple principle. One can use a dual lumen catheter when you have a treaty bifurcation with angles that require backup of force and a directional side branch wiring, when you have a tortuous side branch muscle region, and also when you have a type of ABCDO region. One of the most important concepts is to remember that the use of dual lumen catheter opens the properties of the selected guide. increasing the penetration force to get the support. Of course, when you are in trouble in crossing one vessel, you one example of a problems after a detailed crash in crossing the first diagonal branch, the using of a double lumen can be easily allowed to get access to the branch. What is very important is to have immediately a judgment on the reason suitable for complex technique in crossing. The time of they had a wide terminal angle in white and a narrow takeoff angle in blue is the most ideal for having a dual character and to have a reverse wire technique and approach. You can see the long list of the dual lumen character, and you can say that there is some sort of a consensus that the polygon-junction hydrophilic coating guide wire is more suitable in this case than the conventional spring coil guide wire. There are three essential steps to be taken in mind. The first is the shape of the tip, and the angle can be much more rounding curve, sharp curve. Then there is a second step that is the system delivery before the reverse wiring. And then the last one that is when you have especially this round curve. The last one is the microchemical delivery after the reverse wiring, and then the mentioned the needed to exchange of the guide wire at the end. Here is an important point when you are crossing one branch, the angle might change significantly, as you can see here. Additionally, beside the dual lumen catheter, you might have a different type of technology. You might have angulated microcatheters. The suggestion is to try to choose a large bender, and then we have deflectable microcatheters, where you need to check the compatibility of balloons and wire before, and of course, we need to take in mind some risk of damage of the vessel. One of the most indicated use of this supercross catheter with potential capability of application is when you are facing one 101 condition, likewise this bifurcation between the circ and the marginal branch. Of course, then you can go more aggressive and use eventually one guide wire for chronic occlusion, while the consensus document of the ABC is not strongly in favor, is not generally recommending the balloon block and support technique, only if you don't have available in your lab a single dual microcatheter, as well as is not strongly supported the main gas balloon pre-dilation, and but this should be considered as the last resource. Here you have an example of how you can occlude the vessel and how you can use a balloon block stop technique for the crossing. Here you have another example of the block distribution before the access of the branch, and then how when you are just using this pre-dilation, despite that you reset to get the branch occlusion, you are significantly changing the angle of the side branch. Very important to remember the cherry balloon technique for side branch in protection in a challenging anatomy. Here, the key step is after having placed this uninflated balloon, and before inflating, is to advance the main gas of the balloon that is going to be used for the pump. Here you have another possibility to have protection and rescue of the side branch using a corsair catheter that's making a small space on the balloon forgetting the learning something. Last chance, really last chance, is the reception and community. There are no so many data, but there are some data showing that in selected patients, you might use this technique and quite acceptable success. In conclusion, typical side branch extension can be their outcome in case of side branch deterioration. Key are selection of optimal working means, watch the management about the plaque distribution and the bifurcation angle, including the arena angle, knowledge of what is available in terms of device and neuropractical is crucial, and at the end, reaccess and more complex activating vessels can be, we need to try to predict the vessel at the risk of watching the anatomy to prevent the profusion and eventually to be ready for the treatment in LR. Thank you.
Thank you. A very nice demonstration and, of course, lecturing side branch. In most of the cath labs, especially the new cath labs, many times young interventional cardiologists would like to leave with a simple provisional stenting. I just wanted to know how much time would you like to advise to the young cardiologist to give it the dual, especially the dual microcatheter, you said dual lumen. Because even with dual lumen catheter, and you have a very tight stenosis in the side branch, including a CTO. So it takes how much time would you really like young people to devote before actually leaving it?
It means practically how much?
Time. I mean, you see, because you see, it says the dual lumen catheter, many people are not using it, and many cath labs do not have it also. So when you have a large side branch, more than 2.5, you would like to protect it, and you would like to do the best testing, and you are not able to cross it. So normally in your practice, when you are using regularly, it should take not more than 5 minutes to cross with the dual lumen, or it takes a little more time?
I think a little bit more time is needed.
Okay, thank you.
The patient is the very presentation. Most of the time, we are facing that already also result. Not only the challenging anatomy, but the changing anatomy. If we part the cell into the distal anatomy, the result of slap is getting painful, whiplash. So what would be your approach to protect yourself or to change over from provisional to capital in this scenario? Where will be the enemy of civilization?
I think that the trend is starting to be very
There are OCD parameters for predicting the side branch, whether you get jeopardized or whether you can see the side branch. How relevant are these OCD parameters, and how is it practically possible to do these cases?
So the total OCT is the longitudinal view from iris, the HD. You can see much more clearly the prolonged carina, or the case of the carina is short, if the carina is involved or not. So with imaging, it's easy to get some idea, and some potential idea how much you are going to check. And we saw before also that the sizing of the stent is going to be important to understand how much we can push the carina. So normally it's less than 2 millimeters, the distance between the takeoff of the branch and the keeper of the carina. But of course it depends on the lock from the angle, because that is going to change the lead and depend on the
Turn your flashlight on.
So when we talk about side branch access, lateral access, we see chances of failure, there is some failure. So when more provisional stenting, the re-access to side branch is difficult to provisional more often than to crash or the two. So there are a lot of factors play and it's very observable imaging and how to optimize anti system.
Yes, thank you very much for inviting me to talk about something that is always difficult to talk about in case of practice, so that is not very well. So, when we have a presentation, we always talk about the two different actors. So on one side we have the main lesson, on the other side we have the sidetrack. And we want to achieve that, so we use the perfect technique for maintaining the main lesson open, and also for not using the sidetrack. And for the time, so we ask ourselves, imagery or anti-research. So I think that with imagery, of course, so we have better estimation of the meters, then so we may use a better visual preparation, and we may assess what the result, even more than with the hand, because sometimes also it is challenging, so to estimate. But of course, there is no discussion, because if we look at the guidelines, we have the DSC guidelines, so it's a one-way indication for imagery. So when we use the complex vision and dimension representation, and on February 27th, so it goes also the one-way from the guidelines and from the medical part of the system and medical code. So these evidence so it's coming from many studies, so here I just made a summary of those more important studies. So I included the different kind of interpretations, percentages, different kind of techniques like positive analysis, but all of them so were positive, so although they didn't core because actually included the only 10% of the interpretation, so it was not so positive, but always in favor of images when we do PCR interpretation. So especially October was included the 100% of application, and we all know that OCT was the main technique, which was allowed in the interpretation, to be good, and positive results are 2 years follow-up. So when we look at the application, so when we do all these different factors, so plant preparation should be excellent, we have 3 dimensions, we have to do optimal preparation. And of course, we have to do our best job for our patients when we do 2 steps. So let's go one by one into these different steps. So plant preparation is important. So here we have one from the left to the right. So from the back, which are becoming more necessary. And of course, plant preparation should be more aggressive at the right-hand side of the slide than the left-hand side of the slide. So imaging is not just telling us how much aggressive it should be, but also we enrich a better plant preparation. Because, for example, if we have done a preparation with another kind of balloon and we see that the calcium is not working, so of course we are going to something like that. So this is something that only management can tell us. Some of that is the fourth step. So we may use this formula on the right-hand side. Otherwise, for the practices that we have, for example, in this case, and not be good, but we look at the example to measure the distal reference, the proximal reference, the total length of the stent that we will work in the plan. We may also look at the side direction where this is bigger, and then we may also select the side of the box balloon for our application. This step is very important because we will have to forget that stent that we have in the field, there are some mobility for extension. So we have to use the stent which is good for the distal main vessel, but it's also good for the proximal main vessel. So once we have the stent, so the work is not done, so the capital of imaging is still there in our table, and we may use it for optimal stent. So we have the proximal, the distal portion of the application, we have to reach at least 80 or 90% of the proximal of the distal reference, according to where we are in our presentation, or otherwise, so we can use this table, which is coming in the instrument and material of the file. So according to the standard that we are implanting, of course, for the scope, the use of file will be too low when we use a standard which is 3 or 4 millimeters of even 5 millimeters in guideline. So the work of the imaging of that extension after this slide is not just for that extension, but we have to do also thermal position, which means another way to call the thermal extension after the interpretation or HSA. A particular point for imaging interpretation is to recognize where our wiring is coming from. So as soon as we have a stent, so we make a hop, and we want to make some pieces. So we have to look carefully whether the wire inside direction is taking the proximal part of the application in a level of application, because we want to open some of the spots of the stent towards the application. If you remember in that photo, there were 15% of the pieces, so where this external memory was not totally done, even the most expert preparation is locally, and most of the time with coach members. Why is that? Because actually the cross system of proximal that starts for the applications, we have open a different their side branch. In the CDR, so we have a wider side than we have this side of the body as compared to the proximal, because when we do the physical load, we just make it stop it to the system, but for the proximal, we are creating this metallic energy, or that's the middle, so we are moving metallic inside the application. Last but not least, so we, of course, we may use a filter fabric as well. So of course, also here the average of many medicine is just look at the work of study. But the rest is the same for the inside. Everything is the same, so we have coverage, so it's not means, so please remember that imagery is our life, so when we make an application, so we have to do a negative preparation, perfect size, and also the of I guess that everyone will enter in a cellar room with his back or what's to and looking at the light, and I think that every time will be able to.
Thank you very much for a very basic presentation. My question is your basic question. Would you like to change to instead of imaging or angio, instead of that, imaging and angio? Because without angio, we cannot do the intervention. They are like hand and glove. And glove is nothing without the hand.
Yes, exactly. So we are also dramatic imaging that something. And the first thing that we see when we do a scan. So I would say maybe imaging on the top. But there are some, for example, options like and those are quite useful when we do our application. So we understand how the
I hope it is not NGO imaging for all. I mean, wherever you can use it, should be used, or you feel that if it is available, should be for all.
I mean, I would say that application that is a must to me, so that it should be 100% of the time, because in that case, we are concerned with research, so we have to do our job. Two-step technique also is 100%. And other thing that we can use is, for example, what is the lowest technique we use? So we can see with the angle always conforming to the saturation, and we also be sure of that. Of course, there are some applications that are quite simple, that you are not requiring angle, that you don't require imaging, unless there's something is going wrong when you do it, and then you can gradually get this guide and the imaging later on. Also, technique we adjust for OCD in our convention that. Yeah, I think that so actually it's depending from your practice. So to me, it's fine. It's not necessarily OCD that is an so unless it is happening. So what is better is to use the one you are more to use it, and just not to look at the filter, because everyone is looking at the filter and let's go out from the map, just to take the map and make a measurement to be sure that you are following the filter, where you are, and then you can take time for looking at it, but it doesn't matter if it's positive either, so I would be happy to use it.
Thank you.
Yes, yes. Definitely, yes, that would be just one thing. So, for example, we say the very environment, I would say that
Thank you, sir, for this presentation. Let's now move on to Dr. Guran here from Master. Provisional approach is my different.
Thank you very much for the invitation. It's really privileged to be here again. My task is provisional in my way. These are conflicts of interest, and since the beginning of randomized comparison between provisional and systematic two-step strategies. What we see is that none of the studies actually showed the benefit of systematic two-step strategies, even in EDC2, in which we compare cohort and provisional in large trial analysis. However, when we follow patients and we need to study for a longer period of time, what we saw is that the longer the follow-up, the higher the difference in all-cause mortality. Two-step strategy actually increases the risk. Period follow-up with symptoms confirms the same, including the left main. We have two main messages from the symptoms extended follow-up. First, there are certain critical complications, which is not something that impacts on the outcome. So whether or not there is vital or surgery is not happening. However, for PCR, if we give coronary vital cases, we have higher benefit and the same consistently regardless. One-step strategy at the long-term follow-up increases the rate of movement of 3,300 patients in 9 randomized trials were followed up for at least 3 years of follow-up with minimal loss of follow-up, and Dr. Ford published this important meta-analysis with the primary outcome of all-cause mortality. And you can see consistently that in all trials, including the class 5, everything is on the side of the provisional for the lower risk of mortality. So, two-step strategy increases definitely the risk of long-term mortality, and the longer the follow-up period, like for these 5 studies, which follows 1,700 patients for 5 years, we see that mortality risk is even higher than longer risk of follow-up period. For those reasons, European verification law, as features for treatment of verifications, defines the following. So, it is simple and safe, try to reduce the number of samples, but key is to respect the original verification anatomy and try to reproduce this anatomy using two. Our goal is to learn terms as well as functions and try to limit the error. And this can be translated as original by the training strategy as a gold standard for most applications including learning. And these are the 5 steps of provisional. For us, provisional does not mean single-step strategy. And this is very different to misunderstanding. When people say I did provisional, they say it's single-step strategy. No, it's actually sequence of 5 steps in which we increase complexity. We only do mandatory steps, step 1 and 2. People understand with the reference diameter of the distal main lesson, where you can have and do proximal optimization to reproduce fractal material modifications. Then we are happy with the result. If the result is good, especially for non-FPN applications, we can almost stop at this stage. If you can compromise the cycles, you exchange values, you do pieces with or without report, and then you again stop and allow the result. Now you can get a good result of your cycles, you can stop at this point, but you are increasing complexity, and you don't decide whether I need upfront research or not. If the result after treatment is not acceptable, then we go to step number 5, which is stamping of the subject as part of the provisional treatment. This slide to OCT really shows you key feature of application anatomy. So coronary vessels don't take linearly. Actually, at every bifurcation point, you can step down in diameter. And for that, you need to understand, for that, you need to understand the maximum expansion capacity of the stents that you have on the shelf. And this is inflation of 5 millimeter balloon. And what we see here is that most current platforms, when overstretched with first 5 and then 7 millimeter balloon, can be expanded up to 6 millimeters instead or C. Should we select always according to this parameter? These are very special data that we try to apply this in clinical practice. If we use imaging to assess vessel diameters, and if we can accommodate a larger platform according to its functional capacity. What we try to do is to go with slightly oversized cells deployed at low pressure, nominal pressure, each balloon 30 to 30 seconds, and then do protocol optimization with larger volume. In that case, in the case of adequate diameter selection, for example, is 3 millimeters, with each balloon for what we destroy the architecture of the stent in the corridor. But with slightly oversized quantum, we should be able to fully expand the stent in the proximal of the vessel. And from the October, we have data that image-based selection of the device is safer and better than the already selected device. And the final step, fixing balloon inflation in provisional is just optional, especially outside of the normal FDA. We don't have clear evidence that use of fixing balloon inflation improves the outcome, especially for normal FDA application. Should be done properly with two short testicle ones, five according to visual reference diameter, in sequence to the type first diagram on the main line, two balloons inflated, and then simultaneously deflated. By doing that, we are actually able to reproduce this original fractal anatomy that I showed. This is the opening of the sideburns, the opening of the main lines, and when the belief is sent, we really actually in two nice metal lines, one is the director, we show that if the lesion of the sideburn is shorter than 10 millimeters, there is no merit in the percent. It has to be longer than 10 millimeters. So we recommend electric value strategy for long lesions, high foot compromise, or different access. But even when we do 20% strategy, we recommend to go provisional. And this is the provisional pathway based on the assessment of the risk of occlusion of the side branch after main exercise. If that risk is low, then you do classical provisional, and then you do pick up of the lock depending on the anatomy and blood distribution. If you have a immediate concern, there are two pathways. One is to start with wicked pressure, very popular here. The other one is to do reverted provisional, sending from the main vessel to the side branch, and then finishing with another feedback or flow. We define the steps in the 18 or 7 bottom of the protocol, and now we have the evidence for systematic use in the left main image guidance, less convincing data for non-left main images, but in the rockets registry, usually we show the benefit of that larger guidance, and the October trial, which is already mentioned, did prove that benefit. But we need to be careful because unintended standard deviation is present in 10% of non-overall, in 18% of late applications, and it's undetected by the operator during the procedure in 50% of cases. And if you don't see, if you don't correct, makes the rate of 90%. So we need to carefully use imaging and react based on imaging, not just use imaging. So I would like to conclude that step-by solution is logical, straightforward, versatile, and is strategy of choice for most non-left-hand applications. Two-step strategies may be considered for important side branch with complex integration. Two-step difficult access or risk of compromise. The use of imaging physiology is strongly attached to design strategy and optimize the result of this. I thank you very much for that.
Thank you. Very nice presentation. Just a quick thought process. When you're doing a provisional stenting and you are thinking that you have to dilate the side branch, there's some sort of a requirement. Do you think that in such cases, although we have no data, drug-eluting balloon can be a better option when you are trying to use it rather than a simple or compliant or non-compliant balloon?
I came personally very positive intuitive attitude towards the use of this image of the side branch, but unfortunately there is no evidence. All the studies that we currently have are actually negative, except for the study by the patient DCB. But in that study, the only difference was the lower rate of MI in DCB group. So it's somehow counterintuitive. So until we collect more data and we have some other random studies, I will be careful when you.
But empirical use is not harmful, at least. It can be useful, of course.
We don't know.
Okay.
So what is the goal of setting the provisional government for the tax technique for law technique, which is important?
Yeah, I have to say that it depends, of course, mainly on what distribution and bifurcation range. But one which is most forgiving for bifurcation under probably been the risk on the time.
So very useful presentation, thank you very much. My question is the snowball effect. This is more like a traditional one or like a bifurcation? How do you prevent the snowball effect?
Yeah, the high risk of compromising by pushing the clock eventually, at least validity, if you get clock on the same side as the optimal side and each bifurcation angle is the other. So narrow angle and proximal clock location, not opposite, but on the same side of the bifurcation. This is what I do.
So, I think you might say all the definition criteria of complex application. So all patients in body complex category should be getting into two-stage criteria upfront, or would you like to again subgroup them for for instance as well as some of the cases?
Yeah, I have to disagree. I'm really sorry for that. What we have in the definition tool is our original length in the side length of 20 to 22 millimeters. If you have a sub 20 millimeter region in the side length, of course, F1 has better result with stent than with balloon, and we know this is 1994 and stent and varies in balance. The real law shows that most bifurcations are within this limit of 10 millimeters, and that's why we believe that most of them can be successfully treated originally. And you don't need to decide that upfront whether you need one or two stents. You just follow these 5 steps, you are home, evaluate each step, and then there is always time to put something.
Thank you. Thank you, sir.
So, sir, as a rescue prevention strategy, you are looking about inverted threats versus inverted pull-out.
Okay, personally, both are good. I prefer inverted pull-out instead of internal crash. But according to John Robinson, if you do bench studies in inverted crash inside the tank, there's actually a problem. So if you like it, that's if you want, you can do that as well.
Thanks. Now it's time to one of the next presentation. Thanks again for your presentation.
Thank you very much for giving a chance to talk. My topic is known as Indian bifurcation. Yes. Can I go? So, yes, it is my choice, but in some cases, as we want to discuss earlier, the question is where, why, and why not now? The problem is, it is not because the two-stage strategies are bad. And as far as short-term outcomes are concerned, there is a last 15 years. So, Dr. Goran was talking about all the trials which showed that we are the ones effective. But these are the newer state platforms, and this is the data analysis by 2013, and it was published in 2022, and it shows that upfront two-stage characteristics can reduce everything. Target decision artificial function, target decision depersonalization, and state functions, all are less upstream two-stage techniques. So, two-stage is a very complex bifurcation. They communicate that two-stage is a very complex bifurcation, but in simple bifurcation technique, simple bifurcation,
provisional is in course or limited. So, what is complex algebra? Again, you are certainly talking of definition too, but it indicates a pathway. But there are other, scoring also, the bifurc scoring and resolve scoring, which show that there is a complex bifurcation structure, which and in the relations as well as non-linear relations, and where there is in non-linear at least, where the sidelines is more than 90% stenosis, and it is more than 10 millimeters length, the relation is more than 10 millimeters long, and any two of the these subsets and bifurcation angle less than 45. You can make this a reference diameter more than 2.5, you can large in diameter, and maybe even the region more than 25. So these are of the 5 or 6 subsets. If two are present, then it becomes a physical subset or a complex subset, and it requires to be two samples from the beginning. So then you can go with an angel. It's like this is a 60-year-old male, hypertension, diabetes, and presented with ACS and central angina, and ejection fraction is 40%. And you can see that there are two bifurcations. First of all, in a circumference, you see the dominant circumference with the two very large waving branches. Actually, it is waving one and one on the side. So, we thought of doing a simple bifurcation provisional to the LAB and two-stage bifurcation to the circumference. So, what are the two-stage strategies? And in this meta-analysis, if you look at this picture, you will see that decay crash is the most important two-stage techniques, and it is having all good things in comparison to pull-out and other techniques. But after that, in one at least, we have another article which shows that double piecing pull-out is equal better than decay crash, and so the jury is not out. So we did not have that, these two techniques. We had our paper which is nano crash, and this is our published paper, and we planned same thing up as I told you that I did a provisional sending to the LAB, and it is a port size port actually, and we put a port size port take it to the LAB, and then we went to the two ones, and we did a dilation of the artery, both branches with scoring level. Then we put then we went to the balloon in the main branch and sent in the side branch and put the same to the inflated balloon. Then keeping the same balloon inside the main branch, and with the main branch we make a pass piece, and then we put the main branch balloon, we get marked, then went to the side branch, directed that, we get piecing balloon, and we see the final state. So, these are the two branches, one is provisional and one is two-stage strategy. And with that, the basic stage. So the question is, why not in all cases of complex bifurcation you should have two-stage strategy? Now we can ask, but if you look at the data, even the secondary students, you see that our image is not the technique. The means is a neutral. If you have the graphing extent, you can have very accentuated complications, and it is in the tune of 2% per year, and it has got no pleasure, and if you add more metal, it will be increasing more. So perhaps we need to have an option, and perhaps we will be waiting for graphing extent with balloons to come and to fill up the gap between the 2 cells and 1 cell debate. And my take home is, at this point, the two-stage strategy is so effective. Even particularly of its non-lethal bifurcation. Leaky graph, has been tasted and probably of equality benefit. Our nanoprecious also given, but the future probably lies with DED, anesthesia, or anti-proposition.
That patient after the diabetes, present in Paris and it has 1% zero versus 0%. What would be your approach?
In the ISR, and actually we treated such cases. In the left we did balloon dilation, scoring balloon or cutting balloon dilation in both the branches and put two DEs sequentially inflating and actively patient and just giving them.
That means
and sometimes the restoration of the cardiac cycle also this. So neuroplasticity, the world is now to embrace and to refresh or the refresh with new places. What is your opinion on that?
I think in nanometers is more predictive because once included inflated delivery in the milligram and put that delivery is one size smaller, say it is 0.25 smaller in the milligram, and putting the stent in the sidelines to the inflated delivery, there is no point that respiratory movement and cardiac movement can.
I think
You can put it right.
we have to finish off this session and with a small message that you said non-complex, non-left main bifurcation, provisional stenting, and